Pathophysiological mechanisms of both obstructive pulmonary disease known as COPD and Patrick's congestive cardiac failure contribute to his respiratory symptoms of tiredness, cough, and dyspnea. Whilst Patrick ceased smoking 18 years ago, the impacts of 40 years of smoking have contributed to his onset of emphysema and chronic bronchitis. 85% of all COPD cases are attributed to the inhalation of tobacco smoke. Patrick's dyspnea occurs as his alveoli become distended, which increases the amount of air trapped in the lower respiratory tract. This can result in a flattened diaphragm, causing altered breathing patterns to maintain sufficient respiration, breathing from partially inflated lungs and relying on intercostal and accessory muscles, causing shallow breathing and limited air inspiration. Activation of inflammatory mediators from cigarette smoking lead to hyperplasia, hypersecretion of mucus, and loss of elastic recoil, resulting in airway obstruction, reduced ciliary activity, and abnormal dilation of the alveoli, impairing normal respiration. Subsequent vascular congestion, edema, mucus production, bronchial spasms, and thickening of the airway walls also contribute to Patrick's dyspnea and cough. Abnormalities in his gas exchange results in hypoxemia and hypercapnia due to air trapping and destroyed alveoli with increased formation of air spaces and ventilation perfusion mismatch. Patrick's central obesity and BMI score of 29.3 classes him as borderline obese with excess visceral adipose tissue compromising his lung capacity from heavy mass pushing his chest wall and diaphragm. Patrick's fatigue is a common consequence of low blood oxygen that is further exacerbated by his congestive heart failure. Pulmonary edema from Patrick's congestive heart failure contributes to his cough, dyspnea, fatigue, and limited exercise tolerance as fluid in the lungs decreases his vital capacity. Increased sympathetic activation triggers the renin-angiotensin-aldosterone system and initiates the retention of salt and water, exacerbating pulmonary edema and its negative effects on the respiratory system. Hypoxemia and increased arterial carbon dioxide accumulation leads to increased cardiac and respiratory demand. Tiredness and fatigue result as prioritization of blood is redirected to his heart and brain, reducing blood flow to less vital organs such as peripheral muscles. Patrick's history of myocardial infarction, congestive heart failure, COPD, and his associated sympathetic nervous system responses contributed to his tachycardia. Individuals such as Patrick who have a history of myocardial infarction are more likely to present with an elevated heart rate and blood pressure in response to the release of catecholamines, which encompass noradrenaline and adrenaline, responsible for regulating heart rate and blood pressure via the adrenal gland. Patrick's left ventricle hypertrophy and decreased cardiac output due to his existing heart failure forces the cardiovascular system to compensate for inadequate perfusion, also exacerbated by COPD. His heart rate increases to deliver blood flow to vital tissues and organs. Carcinogenic properties of cigarettes also cause vasoconstriction, which contributes to Patrick's elevated heart rate to further compensate and maintain sufficient blood flow. In addition, Patrick's obesity and waist circumference contributes to his elevated heart rate, as excess adipose tissue results in increased blood flow demand to supply the additional tissue with adequate oxygen perfusion. Activation of renin-angiotensin-aldosterone system triggered by hypoxemia results in salt and water retention, leading to edema, hypertension, and tachycardia. It is a frequent symptom of congestive heart failure due to the increased preload and afterload with decreased cardiac contractility and output. Both COPD and Patrick's left-sided heart failure share risk factors such as cigarette smoking, advanced age, and systemic inflammation. Patrick's COPD is caused by long-term exposure to irritants that damage his lungs and airways. The associated influx of inflammatory markers are linked with severe airway obstruction and cardiac injury, where parenchyma and pulmonary vasculature promotes a generalized systemic inflammatory response. His low level of forced expiratory air, increased inflammatory markers, ventilation perfusion mismatch, low blood oxygen, and increased arterial blood carbon dioxide contribute to poor ventricular function and increased pulmonary arterial pressure. Left-sided heart failure, both systolic and diastolic, is often caused by myocardial infarction, hypertension, coronary artery disease, and cigarette smoking. Increased preload and afterload with decreased contractility leads to blood accumulation and pulmonary circulation, causing pulmonary edema. Inadequate oxygen and blood supply through systemic circulation leads to chronic hypoxemia, hypertension, coronary artery disease, worsening of left-sided heart failure, and prolonged activation of the renin-angiotensin-aldosterone system that exacerbates Patrick's peripheral edema. Inflammation from COPD may be a significant contributing factor to Patrick's congestive heart failure. The immune mechanism causes an increase in inflammatory markers that damage their respiratory tract, which over time can increase the development of coronary artery disease and heart failure. Patrick's left ventricle has to exert more force, with the corresponding rise in blood pressure leading to hypertrophy of the heart and heart failure, as the decreased contractility of his heart means he is unable to deliver adequate blood for effective perfusion to meet the metabolic needs of the body. COPD is a cause of pulmonary hypertension and coronary artery disease, commonly leading to heart failure. Hypoxia, inflammation, and destruction of capillaries from emphysema cause increased pulmonary arterial pressure due to pulmonary vascular remodeling. This adaptive mechanism is commonly triggered by myocardial infarction, hypertension, and coronary artery disease. Patrick's pulmonary and peripheral edema from renin-angiotensin-aldosterone system activation and low cardiac output leads to insufficient renal perfusion due to prioritization of flow to his heart and brain. The resulting fluid retention and prioritization contributes to his tachycardia, respiratory symptoms, fatigue, and congestive heart failure. COPD contributes to left-sided heart failure, however, is not the only cause. Both conditions can influence each other. Poor gas exchange from Patrick's COPD stresses his heart and worsens his congestive heart failure, while pulmonary edema and excessive fluid in the lungs impairs his breathing capacity further. Hypertension, cardiovascular disease, and coronary artery disease are the main causes of left-sided heart failure. The high incidence of left ventricular systolic dysfunction in COPD patients is due to systemic inflammation accelerating coronary atherosclerosis development leading to ischemic heart disease, motor alterations in the left ventricular wall, and left ventricular dysfunction. Conversely, COPD is commonly associated with pulmonary hypertension and is the main cause of right-sided heart failure known as cor pulmonale, associated with subsequent left-sided heart failure. COPD patients have increased risk of developing cardiovascular disease, coronary artery disease, and heart failure, as they both share pathogenic mechanisms that interrelate with similar symptoms of dyspnea, fatigue, and exercise intolerance. Smoking and perpetual systemic inflammation appear to be the most common causative factors of both heart failure and COPD, with interactions of the pulmonary and cardiovascular conditions accelerating the progression. Patrick is at increased risk of developing right-sided heart failure due to existing COPD, history of myocardial infarction, and existing pulmonary hypertension and congestive heart failure. Pulmonary hypertension caused by COPD results in an increase in the cardiovascular circulatory system workload, specifically the right side of the heart. The compensatory mechanism forces his right ventricle to work harder, which increases blood pressure, contributing to the onset of hypertrophy, decreased contractility, and right-side heart failure. COPD contributes to approximately 80 to 90% of cor pulmonale cases. Despite Patrick's COPD and previous myocardial infarction, the primary cause for the onset of right-sided heart failure is existing left-sided heart failure, as long-term pulmonary congestion and hypertension increase the afterload and right-sided hypertrophy and failure. His history of myocardial infarction causing permanent tissue damage as well as existing pulmonary hypertension, pulmonary congestion, and edema lead to cor pulmonale. Patrick's decreased contractility and associated pulmonary hypertension, hypertrophy, anemia, and pulmonary edema increase his risk of cor pulmonale. Patrick's renal hypoperfusion as a result of congestive heart failure leads to sustained sympathetic stimulation, which activates the renin-angiotensin-aldosterone system and a cascade of neurohormonal changes. As discussed, these lead to increased venous and arterial tone with greater preload and afterload, myocardial contractility, increased plasma noradrenaline concentrations, and progressive retention of salt and water, reflected as results of hypernatremia and lower leg edema. While these mechanisms serve initially to maintain cardiac output, over time they become maladaptive and lead to the decline of Patrick's heart failure and potential neurological deficit. Hyperosmolality from the intercellular water loss can lead to Patrick acquiring neuronal cell shrinkage and brain injury associated with various adverse clinical outcomes, such as increased mortality and central nervous system dysfunction. Cerebrovascular damage with subcortical or subarachnoid hemorrhage and venous thrombosis can occur, accompanying confusion and neuromuscular excitability. The subsequent fall in GFR stimulates the synthesis of aldosterone and increases his absorption of sodium in the proximal tubules, resulting in his decreased delivery to the distal nephrons and lowered potassium excretion, causing his hyperkalemia. Patrick's hyperkalemia left untreated can have severe consequences, altering nerve action potentials, mostly affecting the heart. Suppressed parathyroid hormone secretion and vitamin D deficiency is common in patients with progressive congestive heart failure, such as Patrick's. This results in decreased osteoclastic bone reabsorption and lowered distal tubular reabsorption, with vitamin D insufficiency limiting intestinal calcium absorption as well. Smoking has also been associated with increased levels of calcium excreted through urine. Resultant hypocalcemia leads to excitability of the central nervous system, impairing his normal cell function, neural transmission, and intracellular signaling. Hemodilution, iron deficiency, inflammatory cascades, and impaired erythropoietin production and activity are some pathophysiological mechanisms involved in Patrick's heart failure-associated anemia. Renal hypoperfusion poses risk for prolonged renal ischemia, with the hypoxic effect reducing the amount of erythropoietin produced in the kidney, with further losses of serum erythropoietin and transferrin through urine, leading to severe anemia and increased cardiac demand. Inflammatory cytokines also shorten the lifespan of red blood cells, leading to peripheral neuropathy and brain ischemia, the most common cause of transient neurological deficit. Patrick's history of smoking and his exercise intolerance contributes to his high LDL cholesterol, as well as consuming foods high in saturated fats and trans fats. Dysregulation of cholesterol homeostasis in the brain is increasingly being linked to chronic neurodegenerative disorders as seen here. His hypertriglyceridemia is likely caused by lifestyle factors such as prolonged inactivity, poor dietary choice, metabolic syndrome, and uncontrolled type 2 diabetes. Hyperglycemia is a common diagnostic factor of type 2 diabetes caused by Patrick's lifestyle factors such as poor diet, inactivity, smoking, obesity, and metabolic syndrome. Both hypertriglyceridemia and hyperglycemia are predictors for neurological and cardiovascular impairments seen here. Patrick is likely to show higher than normal serum phosphate levels. Renal hypoperfusion due to congestive heart failure causes a decline in his functioning nephrons and a fall in GFR, decreasing the amount of phosphate filtered and excreted, leading to hyperphosphatemia. His phosphate accumulation can cause acidosis as reduced hydrogen ion excretion and bicarbonate absorption. High phosphate levels are commonly seen in correlation with hypocalcemia, as Patrick shows. It is known that hyperphosphatemia results in impaired bone modulation and parathyroid gland function.